Good afternoon, everybody. Today we have a very special grand rounds being presented through the Mays Cancer Center, and also in collaboration with our American Cancer Society, Avanzando Salud, our Center for Health Improvement Research at UT Health San Antonio. Today was also a very exciting day. Before I introduce our speaker, Dr. Elena, we had the groundbreaking ceremony for our ACS Center of Hope Lodge. So we are so excited that we've been able to get that off the ground. And for those of you who may not be familiar with the Hope Lodge, this is an opportunity for cancer patients who are traveling from different parts of South Texas. And as many of you know, we cover 38 counties, over 5 million people in our counties. Travel all the way from the border, can be 3 to 4 hours to receive their cancer care here in San Antonio. And they don't have necessarily a place to stay. So this collaborative opportunity with ACS and our Methodist Health Ministries, who helped launch the Hope Lodge today, is really an exciting venture and partnership with our local ACS as well. So thank you. Today has really been a truly amazing day. And we want to give a special welcome to Dr. Joanna Elena from the American Cancer Society. She has been just a true partner. And before I do that, I just wanted to mention to those who are listening, we are fortunate to have an ACS Health Equity Grant from the American Cancer Society, and our center goal is to truly aim to help reduce the risk for cancer for all our South Texas constituents, and also to improve their healthcare outcomes, survivorship, and quality of life. And most of all, we are working with all of you to reduce those non-medical drivers of health that sometimes keep our patients from coming in our service, barriers to them really focusing on their health. So this is truly a collaborative project. It's a 4-year project funded by the American Cancer Society. And we are reaching out also to our early career investigators. If you're interested in working with us, we would love for you to contact us. And Dr. Elena will share a little bit more about these centers with you. But we are here to also help in the career path to focusing more research in these non-medical drivers of health. So I will begin by introducing Dr. Elena. She is a PhD and also has an MPH, and she oversees the Extramural Discovery Science Clinical and Population Sciences program at the American Cancer Society, which is the largest private nonprofit funder of cancer research in the U.S. As a scientific director, she is responsible for research programs development, peer review, grant management for human studies related to areas of cancer prevention, areas of early screening and early detection, cancer care and delivery, treatment, palliative care, and survivorship. Also has a special emphasis being placed on studies with relevance to diverse populations that reflect the U.S. with respect to age, gender, disability status, race and ethnicity, geography, and social class. Research in this program requires data from human populations and may include behavioral research, healthcare delivery, comparative effectiveness research, health outcome studies, or secondary data analysis, implementation science, community-based participatory and practice-based research, and health equity research. Dr. Elena's personal research interests include the design and use of cohort studies and body composition, diet, and lifestyle factors as a measure of cancer outcomes. Before coming to the American Cancer Society, she was a national program director at the National Cancer Institute's Division of Cancer Control and Population Sciences, the scientific director of the NCI Cohort Consortium, of which we have one here in San Antonio in collaboration with the University of Miami and the Mays Cancer Center, called Our Caminos Cohort Study on Latino Survivorship. And she's also responsible for developing and managing several large funding initiatives. Dr. Elena completed her PhD in nutritional epidemiology at the University of North Carolina at Chapel Hill and her MPH at Johns Hopkins Bloomberg School of Public Health. So without further delay, let me welcome Dr. Elena, and we are so grateful that she is here with us today, and we give her a very special South Texas welcome. Dr. Elena.
Oh, thank you so much, Dr. Ramirez. I really appreciate the invitation. And when I left the NCI 2 years ago, I was actually worried that I was going to lose contact with some of the excellent scientists, Dr. Ramirez being one. And I was pleasantly surprised when I got to the ACS to find you are also within our wonderful grant portfolio, and I get to continue working with you. So that's been a nice part of my journey. Now I'm going to try to, let's see, did I get slides? Dr. Rodriguez, I see your face. Do you see my slides in presenter
Yes, I
mode?
can.
Okay,
Yes.
great, perfect. Thank you so much. And also, I've been having some bandwidth problems today. If for any reason you can't hear me or I freeze, if someone will put a note in the chat or let me know.
Thank you.
But again, thank you so much for inviting me. It is really my honor to get to talk about some of the research opportunities for health improvement, health equity. There are many words that we can use, and I know that these times are requiring some creativity. I will tell you that the American Cancer Society remains committed to advancing the health of the US population and all of its wonderful, beautiful diversity. I have my email address on the front screen. Please feel free to contact me. The best part of my day is talking to investigators and researchers, and I am really honored to get to talk to you. And also joining this call is joining my team is our new Senior Associate Scientist, Dr. Alana Roach. And if not me, you can also talk to her. I may forward it to you, but we are both committed to furthering this work. Okay, great. So first off, I have unfortunately no financial relationships to disclose for today. And today, just to orient you, I'm going to start with an overview of American Cancer Society's efforts to promote health equity, highlight some emerging research that we have, and then describe available funding opportunities, which probably is going to be of most interest to many of you. So the American Cancer Society exists because the burden of cancer is unacceptably high. Same reason I know many of you do what you do. Our vision is ending cancer as we know it for everyone. And ending cancer as we know it, it doesn't mean we will get rid of cancer, but hopefully we can alleviate some suffering, we can reduce the incidence, and then for everyone, lets you know that we are interested in everyone in the US and in overcoming barriers and disparities and really taking this vision of ending cancer as we know it to everyone. We do this through three pillars of different programs. The discovery pillar, which is where I sit. We are the largest private nonprofit funder of cancer research in the US, over $500 million in active grants. And we also have an intramural scientific team, and I'll talk about some of the work they do. We also have advocacy in all 50 states in the US, in District of Columbia, Puerto Rico, and Guam. Very important time for our advocacy arm right now. And also they are always looking for volunteers. If you want to work with them, it's called ACS CAN, C-A-N. And then our patient support pillar really launches programs that directly affect people at risk of cancer and cancer patients, and they manage the Hope Lodge. And I really want to commend you all on having a really exciting day today. Hope Lodge can really change the course of a survivorship for people if you don't have to worry about how you're going to pay to stay close to your treatment. It's a wonderful service. So I'm so glad to see that San Antonio is now a proud recipient of a Hope Lodge. So I'm going to start with um, some of the programs and patient support that we just talked about. And what they start is to understand the health-related social needs and their medical and non-medical drivers of health. This is really focusing on the social determinants of health model. And you can imagine there are lots of things that affect where you're born, where you're raised, where you live, where you work, and how you age. And it's different for all of us, and who we are affects our experience. So trying to make sure that we are really improving the health for all people. And think of it sort of like I think of precision medicine. When you find out that you have cancer, they just don't say you'll have cancer and you get medicine. They want to know what kind of cancer you have, what kind of molecular subtyping we're looking at. Tell me more about what your barrier, in this case, the cancer is, and then we'll approach it with the right medicine. We'll approach it with the right approach. And so that's what we're doing for trying to look at how we're affecting some of these social drivers of health. And so taking this conceptual model, then mapping it onto what cancer health looks like. And there are all these when you first think of cancer, you think, oh, we've got to get the best treatment, and that's true. But to get the best treatment, you need a ride to the place where you're going to get the treatment. You need to have some way to pay for your treatment. The list goes on and on. And so understanding this model, then we can map some of our programs. And this is specifically for patient support, the pillar I just discussed. And there are programs here like Cancer Risk 360 just launched to help you think about cancer prevention. Empowered to Quit is for helping you stop smoking. ACS Pause, my favorite, animals that help emotional, social support through treatment. But Road to Recovery, help you get in a ride to your appointments. Hope Lodge, we've just talked about, and the list continues. There are lots of programs, but really built around this framework of how do we help people where they are with what they need. Another really exciting opportunity that's coming out of now shifting to my group, Discovery. And I am on the extramural side, meaning we give out money to places like UT Health San Antonio. But internally, we also are comprised of scientists doing really exciting work. And the Voices of Black Women cohort study just launched in May of 2024. And it is led by Drs. Alpa Patel and Dr. Lauren McCullough, and they will be enrolling 100,000 Black women ages 22 to 55 without a history of cancer. And it's really designed to see what is driving the disparities we see for Black women. Again, using the same framework of where people are, the environmental factors, what they're doing, behavioral factors, things in your zeitgeist, I guess, for lack of a better word, social factors, the clinical factors, your cultural factors, your psychological factors, and biological and genetic factors. And again, all of these factors are going to make up a different, using this kind of pie chart, it's different set of values, but all together is going to represent what is behind some of the disparities we see. And the reason we do these studies isn't just to observe, but really to figure out what we can ultimately do to reduce or eliminate these disparities. Another activity within our intramural discovery team is looking at the annual facts and figures. You've probably quoted these in your grants many times, but taking national estimates and putting out the information about what's different in cancer trends this year, and the I guess center top left here is Dr. Frederick, our CEO, and he's on Fox News, and Dr. Bill Dayhut, our Chief Scientific Officer, right beneath him, on Good Morning America. The reason we are out talking about these things is trying to reach people where they might be, the cover of the New York Times. And we do this again, not because we love being on TV, but because we want to reach people and hopefully make a difference in what we see for cancer incidence, and see if we can, again, get people to better treatments, to get people access to the care they need, and really work on reducing suffering from cancer. So for this year, we had three main points. One, that cancer incidence was rising in women and decreasing in men. Great for men, but we've got to figure out what's going on for women, especially those under age 50. And pancreatic cancer and incidence and mortality continue to increase. And unfortunately, the 5-year survival rate is unacceptable right now for the common pancreatic cancer, most common type of pancreatic cancer. And then again, not news probably to anyone on this call, but there are alarming racial inequities in cancer mortality, and they continue to persist. So it's a call to action for all of us. So back to the group where I am, the Extramural Discovery Science. We fund research. We're the largest private nonprofit funder, over $5 billion of research funding since the 1940s. And one of the most rewarding pieces, talking to people who are very senior who say, I got my first grant from ACS. You made me think I could continue. So we continue to support early stage investigators. And these early stage investigators go on to have some of the most amazing careers. Since 1940s, we've funded 53 Nobel Prize winners. We have funded over 32,000 grants, 25,000 investigators across 1,000 plus institutions. So for what the grants look like for right now, for all of our grants, we're funding a little bit, close to 900 individual grants for more than $517 million across many different grant mechanisms across institutions. You can see the map. We have pretty good geographic distribution, but I think we could be doing better in some of the states. And we have a pie chart here of the cancer types that are included. A lot of our grants are in fundamental or basic science, so those are not site specific. But we do look at what our distribution is, and we are trying to make sure that we're really representing what's going to make the biggest difference to people at risk of cancer and those who have cancer. I mentioned early stage investigators. We are interested in supporting your career throughout your scientific endeavors. In my program, we look at before faculty positions, and we have that supported through postdoctoral fellowships for new graduates within 4 years of your terminal degree. We have early stage programs. We have a pilot program that is for each institution. It's called our Institutional Review Grant, Institutional Research Grants. It gives Block funding to different pilot programs. And then the bulk of, and I'll go through these programs a little bit in more detail, but the bulk of what we fund are research scholar grants. This is the equivalent for us of an R01. It's a research-based grant. Typically restricted to people who are early career. I say typically because if we have RFAs, we allow everyone to come in because we say the topic is so important. We will welcome grants from anyone. And then towards the end of your illustrious career, when you've risen to the rank of professor and you're internationally renowned, we have a professor degree where at that point it's honorific based on the work that you've done. there's a small pot of money that comes with it, and you really serve as an advocate for ACS and further the really fundamental groundbreaking work that you've done. And then we have a few special initiatives that I will get into with a bit more in a bit more detail. So I said we fund research across the cancer continuum. We start with fundamental science. We have preclinical and translational research, and then clinical and population studies, which is what I lead. And they make it really simple for me. They say fundamental science is cells, the preclinical and translational research are molecules, and then the clinical and population sciences are people. So I can get behind that. I'm with the people. We also just started a new program to really start from the beginning of your career as a postdoc to all the way through your career trajectory. And we call this program the Career Growth and Research Excellence Program. It's led by Dr. Kathy Goss and Nicole Lepanik. And we've moved all of the postdoctoral fellowships. They used to be reviewed by your content area of the science. Now they're all they'll still be assigned to a peer review committee that has the appropriate expertise, but you'll be managed in Dr. Goss's program so that we can do a better job, I think, of highlighting some of the opportunities, maybe helping postdocs see what review looks like, understanding the pitfalls of some of the common pitfalls early on in your career. And then also looking at our larger program grants, our institutional review grants, and then continuing through the ACS Professor Awards. And then before you become a postdoc, we have we're very invested in diversifying that pipeline of future researchers. And so Dr. Ellie Daniels oversees our Center for Diversity and Cancer Research Training. Starting at the high school level, we have a summer healthcare experience in oncology, our SHE program. And undergraduate, we have diversity and cancer internships. And then we also have a pre-doctoral post-bac program, and hopefully we keep building into future programs. They've already, just of last year, their reach is immense. They have 500 trainees who took part in their programs across 39 institutions. And it's great to see these numbers rising. Okay, then when I come to our program, the Clinical and Population Sciences Research Program, we fund research grants that investigate how to prevent, detect, treat, and survive cancer in human populations. We will always have, because we are trying to advance the health of the whole population, we're going to always encourage that precision medicine approach. So there's special emphasis for understudied groups. And there are many categories that this could fall under, but these are some of the ones that we're thinking about. And this is the distribution of our grants across the U.S. We have about $160 million in grant funding right now, almost 200 active grants across more than 100 institutions. And I mentioned Dr. Roach just joined our group this week, or I guess last week. So she's an old pro at this point, 2 weeks in. And her email is here too. And together we are building this program. So I have a couple of links here that may be helpful. The first one has a link to all of our grant mechanisms. That is updated approximately in, I think, January and July. A couple times a year, we're changing our fiscal calendar, and so those months may change, but it's worth going back to every so often, bookmark it. And it will tell you what's available. And then once you are actually ready to apply, all the information is in Proposal Central. And those are the two things that I think you really need to understand ACS funding opportunities. So Dr. Ramirez already mentioned our Cancer Health Equity Research Centers. And those were created to address cancer health inequities that affect a local or regional community. This isn't necessarily a geographical community, although it certainly could be. We're taking that word community and allowing researchers to tell us who the community is that they are addressing. And because who you are and what your experience is vital to getting the kind of treatment and access to healthcare that's needed, it must include robust measures of structural and social drivers of health. We're really focused on actionable solution-based research. Descriptive data are necessary at times, but only when truly novel. If we already know there's a problem, we don't want to keep coming back and measuring it over and over. We want to actually see how we can help fix what's going on, or at least study what's going on so it can be addressed hopefully more effectively in the future. It started to build programs in the minority serving institutions, and in the last couple of years we've opened it to all eligible U.S. institutions. It does require a center community advisory board, and we encourage using our local regional teams at ACS to help build awareness and hope, if we can, in the community. Excuse me. And the budget is approximately $4 million a year over 4 years. So total $4 million, and has 10% indirects. And it includes sub-award projects and also core activities for the center. And there's a little bit more about ACS's approach to how we feel about ACS at the bottom. So since 2021, we've awarded 8 cancer health equity research centers, almost $33 million, all amazing institutions, but I'm sure your eyes headed south to the San Antonio. And we also have 2 in Arizona. We have a new one in Oklahoma. We have the University of Illinois at Chicago, and the Morehouse School of Medicine, Howard University, and Mount Sinai. Our priority areas for 2025, and this is the list of things we've identified. But if there's a health disparity that you see as being vital that doesn't fit this list, then it's up to you to make the case in your application. And so these are the ones we've listed: rural communities, so really looking at access to health. Early onset cancers, we know it's rising. Can we figure out what to do? Racial, ethnic disparities, documented every year and just getting worse. Sexual and gender minorities, immigrant population. I don't know exactly how to say this one, so I've been saying age-specific needs, but looking at pediatric, adolescent, young adults, older adults, are there differences based on your stage of life and when you're going through treatment? Issues of environmental justice, this is a long list, and then physical and mental disabilities. And when we look at this, we do want to see distribution across the US, across cancer sites, across research priority areas. We're trying to balance it to make the most impact across the US population. And one of those excellent centers is right where you are, the ACS Avanzando Center. The aims are really looking to reduce the burden, the health inequities across South Texas by implementing training, patient assessment, health leadership that is addressing those non-medical drivers of health that deter patients from the access to cancer care, prevention, early detection, treatment, ultimately hoping to improve patient outcomes, survivorship, and most importantly, the quality of life. And so there are four big goals that this beautiful, smart, motivated team is leading. So thank you to all of you on this call for your tireless work. It is very much appreciated, and we are just really proud to be partners with you. When we are looking at so we are looking at the health of the population. We are also trying to grow our workforce, and so it's important to us to know who's applying and who's being awarded the grants. And so we've done fairly well at having similar ratios of who's applying and who's being awarded. I think we can always do better. Um, and this is only for the principal investigators of the center. When you look at the teams, I think that the teams, I am constantly impressed with the diversity of teams based on age and experience and research topics and the personal characteristics of the investigators. So I am also proud of that. So getting into a few of the different mechanisms that are available, I talked about our postdoctoral fellowships. Um, and I think you know why we do those. Eligibility, you need to have had a doctoral degree for less than 4 years from the time of submission. Now, we understand life comes up. You may have had parental leave, you may have had medical leave, you may have stopped your career for reasons. If there's something like that that puts you outside that 4-year period, we do have an email address, I think you'll have to look in our on our website, but I think it's grant, singular, not grants, plural, but it's either grant or grants dot eligibility at cancer.org. And you can explain what happened, and then you can get official notice that you would then include in your application. And you can always reach out to me if you can't find that email address. Then, depending on where you are in your career and what you think you'll need, you can have 2 or 3 years of funding for your postdoctoral fellowship. And it's a successive salary from $66,000 to $70,000. We give you a little bit of money to travel and to have an allowance to do things that you need to do related to your research, and you are permitted 2 resubmissions. Our other mentored grant opportunity is our Clinician Scientist Development Grant. Thank you. And this supports clinical faculty, someone who has patient-facing responsibilities and is currently licensed. It could be a physical therapist, it could be a speech language pathologist, a psychologist, a medical oncologist, anybody who has that patient-facing responsibility. And they have a good clinical career going, but they are trying to launch a career as an independent researcher. And so at that point, this is going to be a mentor grant. So you find a mentor who's going to get you where you need to go to be a successful independent researcher. And again, depending on what you think you need, somewhere between 3 to 5 years and $135,000 per year in direct cost, plus 8% indirect cost, and you get only 1 resubmission for this. And then our research scholar grants, which is sort of the equivalent for us of a R01, if you're familiar with NIH grants. It's a research-based grant. It's up to 4 years and $215,000 direct cost a year over that 4 years, plus 10% in direct cost. And because we really are trying to launch independent research careers, these are restricted to investigators within the first 10 years of their independent research or faculty positions of your initial faculty, within 10 years of your initial faculty appointment. And you also can't have more than 1 R01 like equivalent grant. And you get 2 resubmissions. We also have a 2-year grant called a Discovery Boost Grant. And these are often analogous to like an R21 at the NIH. in the NIH model. But really what we're looking for is more exploratory research. You are not required to have preliminary studies. You can certainly put them in if they help, but you're not required to have them. And these are looking for more high risk, high reward type projects. And it's always tricky, I think. I've always had trouble really identifying what's high risk and high reward. So I try to focus more on the high reward piece. Um, if it's going to make a big impact and you can do it in 2 years and it's a bit more exploratory, this is your mechanism. And you only get one resubmission. And I saw, oops, if I'm going to be able to do it. I saw there was a chat that popped up. Okay, here we go. Let me see. Oh, great. Thank you. Alana put, it's grant singular dot eligibility at cancer.org. Perfect. Thank you, Alana. Okay. And I mentioned earlier, we have changed our fiscal year. So we had previously had applications come in, I think it was March and October. Now we are having applications come in June and December. That means that for I guess the upcoming cycle, the June 1st submission date for 2025, we'll have peer review completed in September. We'll finalize our funding decisions in December, and you'll know in January, and then the grant will start in April. So it's less than a year from submission to starting, which is, I know, too long for you, but pretty fast considering everything that has to happen on our side. And then we'll do the same thing again in December. So this is our process. It's very similar to NIH. If you're familiar with that review process, you submit the application on proposalcentral.org, I think, but Proposal Central. And then it is assigned. We, Dr. Rocha and I will honestly look at every single one of the applications that come in and assign it to a peer review committee that we think is appropriate. You also have the choice to select the peer review committee that you think is most appropriate. And then we really do our best to make sure you have qualified reviewers who I have to say, I've really been impressed by the ACS peer reviewers. It is often a labor, it's a service. I know we always say reviewing grants is a service, but I've really felt that they take this job very seriously. And I know it doesn't feel like it when you get your summary statements back, but they really want you to do well. And they are really trying to help you be as successful as possible. And so if you can find the kernel of wisdom in reviewer critiques, take it, because I think it really is intended more often than not. So it's assigned to a peer review committee, and then the peer reviewers get together and they'll do their initial scoring, and then we triage a pretty big amount to save everyone's time and also knowing what our funding budget is to be appropriate. So we probably, depending on the study section, probably triage 60% or so. And so don't take offense if you see that your applications are not discussed. It doesn't mean it won't be funded the next time. It just means it wasn't ready to go as is. And it probably the discussion wouldn't be of benefit. So then we come together and we discuss the best scoring applications, and then rank the applications, try to set what we think is a reasonable group to go forward for consideration. At that point, it goes to leadership and ACS. We make our recommendations, trying to figure out how much money we have, and we really love funding grants. So if we have the money, that's where we're putting it, and we are always hoping for more. But we make those recommendations for funding, and then you are notified with the final decision. One thing I think is a little bit different from the National Cancer Institute or NIH, which I know most people are familiar with. We do use numerical rankings when we are talking within the peer review group, but what is reported back to the applicant is only the adjective. So you'll know that outstanding corresponds to less than 1.5, and that is our fundable range. And at that point, it's ready to go as is. There might be some minor concerns, but if you don't fix them, no one's really concerned. It's ready to go. And then anything that has um, a minor to more egregious flaw, um, those go from excellent, good, fair to non-competitive. And I will always say that this isn't like an iterative process. You don't start at a fair and then go up to good and the next time go up to excellent. I have seen things that are not competitive go up to funding the next time, especially when there are concerns in the approach. You can fix those. And then I'll just give you, these are just my opinions. They may or may not be right, but I've been observing peer review for gosh, almost 20 years at this point. So this is what I've taken away. So here are my tips for success. I think if you have a clear and appropriate research plan that's supported by past work, that you address common pitfalls, a lot of the work, especially when you're looking at understudied populations or groups that have not traditionally been involved in research, I think sometimes the tendency is to try to hand wave over it like it's going to be fine. But I actually find the folks who are better at reaching groups know those common pitfalls. And when you let your reviewers know that you're going to be flexible, that you may go to additional sites if recruitment isn't up, um, that you'll pivot and learn to use online platforms when COVID hits. You know, nobody could have foreseen that. But actually, I think it inspires more confidence in the reviewers when you say, if we run into problems, these are the things that we've seen in the past, and this is how we're going to address it. And then make sure that you show that the needed expertise is present. It doesn't have to be you. You don't have to know everything, but your team together needs to be able to address whatever is necessary for your research to be successful. I also find if your results are informative, regardless of the specific findings, that always bodes well. Kind of goes back to you often see that the aims are interdependent and people are worried if aim 1 isn't successful, if then what happens to aims 2 and 3. This is sort of that same idea. You just want to make sure whatever you find is going to move the science forward. I think demonstrating clinical relevance or showing that it's going to inform guidelines or practice, I think there's no better way to show how important a project is. If you can show the impact on the people you're trying to reach, I think that helps you tremendously in that significance section. And then again, just a clearly defined problem, a focused proposal, for us, one that's highly cancer relevant, a manageable scope that's easily digestible and free of typos. I always picture your reviewer, um, for me, I don't know why. I always picture a woman. She's always in the window seat on an airplane. She's printed out your application. She's coming back from a conference. She's tired. She's really given it her best. But if you have hidden something in an appendix, she might miss it. And she's trying her best. So make it as easy for her to understand what you're trying to propose. And in that vein, I always think a good strategic diagram, especially for an overview of the whole study, anything that you can make sure that they see, because people will make mistakes, but I think they generally are trying. So the more digestible you make the application, I think the more enthusiastic they will be about the work. And you want to just make sure that they don't have to hunt too hard. And the free of typos, it's such a minor thing. But if you say that your population size is 500 and the specific aims, and then your analytic plan says that you're looking at 492, but you don't mention what happened to those 8 people, for the right reviewer, that will get them stuck for the rest of your application. So those little things seem so minor, but they actually, I think, add up for you. And then I would say start early. I know easier said than done, and I'm the worst at it. But if you start early, then you can share with your mentors and I know things are changing so quickly right now, and especially in the past few months, but no one has a better insight into what will happen than people who have been there before. And a great mentor will really help align you with what you need. And then I also think sharing with a scientist outside of your field, someone you think is smart, someone who should get what you're saying, if they'll look at your aims, if they don't understand them, you're probably in trouble, because maybe, I'm going to say, maybe you're looking at breast cancer outcomes in Latina um, first generation women in Texas. Maybe you find someone who understands the landscape of um, breast cancer outcomes, or maybe you find somebody who understands access to care in Latina women. Maybe you find someone who understands Latina women in Texas. But chances are you're probably the expert in that interaction of things. And so you need to make sure that you're not just writing to someone who knows what you know, that it is somebody who can follow. You need to take someone there who maybe does behavioral health and, um, prostate cancer survivors or something. You want to make sure that that you are taking the reviewer to where you need them to go. And that's the end of my slides, and I'm happy to take any questions. And if you're not comfortable sharing here, you're welcome to email me.
Great. Thank you so much, Dr. Elena. Yeah, so we're open for questions. If anybody wants to put anything in the chat, or, just unmute yourself and feel free to ask. Obviously, just some wonderful opportunities at different levels. I know that Dr. Robin Leach and also Eva Garcia here, we have some of the training grants that we're really excited about. So if any of you who are listening in the audience work with students, please reach out to Dr. Leach or to Evie and let us know, so maybe they can be invited and incorporated into the training opportunities that we're going to be offering through the Mays Cancer Center with support of the American Cancer Society. And the American Cancer Society is really giving us those opportunities where we might find ourselves not being able to apply in other locations. So I think these are wonderful things. And so Dr. Lena, if someone has an idea, do they, I know like with NCI, we used to call our program officer and talk to them and kind of share it with them. Is that also an open opportunity?
I love it. It helps me if you have a draft of a specific aims page. If you have something, and I'm not gonna look at it for typos and all of the things I just told you to avoid, but if you put something down on writing and email it to me and ask me to meet, I'm always happy to do that. And also, I also just want to caution people. Um, when I give feedback, it's just from one person's advice. And this is, I think, true at NCI, at ACS, anywhere if it resonates with you, then take that information. If it doesn't, really think about it before you change everything just to fit. Now, if I tell you it's not within scope of this announcement, you're going to have to change it. But if I say, well, did you consider collecting information about quality of life? And if that doesn't fit in your budget or scope of your research, then you can say, yes, I considered it. But I just try to be helpful, and when I talk to people, and don't don't call me and say, what population are you interested in? I can look at any cancer site. What do you think I should do? Because I can't. I'm not gonna, I can't take you there, but I certainly can help you say, we have a health equity center, and we are in Corpus Christi, and we are looking at if it's exactly what just was in your center. I can say, that it's available on the website. You can see that UT San Antonio already has a cancer health um, equity research center that's looking at these things, really think about how you would be different. So I can do that sort of helping you position, but don't think I'm gonna read tea leaves for you, because honestly, I am still really bad at guessing what the study section is gonna do. The grants I am positive they're gonna love, they don't always, and vice versa.
Any new changes going on at the American Cancer Society that we should be aware of, and the coming future?
Not, I think I think we're pretty steady moving ahead. I I don't think anything notable is changing. I think we're trying to do more of the same and find what's been successful and stay true to who we are, and hope to and also identify some of the gaps that where the government is changing priorities, hoping to step in and maybe fill some of the unmet priorities from where they have been previously, and see if we can maybe make a difference there.
Just a wealth of information that you've shared with us. And is there anybody else on the line that would like to take this opportunity to ask Dr. Linda any questions?
Well, I've answered all the questions.
I think
This is great.
we're done. No, well, thank you so much, Dr.
Oh,
Linda.
wait, sorry. I think there's one that might have
Okay,
popped up.
I'm
Oh,
sorry.
just thank you. Never mind. Okay.
All right. Allison, did I see you coming on? Any questions? You're muted.
Can you hear me?
Yes, thank you.
Any concerns that you have in the near future about the ability for ACS to fund projects with a specific focus or particular terms in their primary aims or outcomes, including social determinants of health, questions around equity and diversity?
I don't, from ACS's perspective, we remain committed to all of those things. What I have noticed is sometimes at the institutional level, some institutions are encouraging words and topics. And my concern is always making sure that you are successful. And so if we always want to make sure we're not setting you up for future trouble, there's no problem. You use whatever word you need to describe the science. But we know that we don't exist only in a vacuum. So if things make sense for you, for your institution, or even for publications, we're open. We're living in unprecedented times, right? So I think we're all just figuring this out as we go. And I am always happy to have those conversations. But ACS isn't worried about what words you use to describe your science, but we are worried about your career. And so we will work with you however we can do that.
Thank you.
Sure.
Thank you. Just nicely said. We appreciate that support. Thank you so much.